Yes, sir. Yes. Good evening, sir.
Navin, good evening.
We are not seeing him.
Yeah. My video is off because I am at the hospital and I am working with the mobile.
Oh, okay, sir. Okay, right.
Okay.
So President is also there?
For bandwidth. Dr. Siva, just now he joined with the, I left the trauma webinar and I came here.
Oh, yes, simultaneously trauma is also starting.
Yeah, it's 6 p.m. both.
Okay.
So can we start?
Yes.
5, 4, 3, 2, 1. We are live now. We can start.
Yeah. Thank you. Good evening to all. Once again, I would like to welcome you all for the webinar, second webinar of the IOA Subcommittee, Arthroplasty Committee. And to start with, I would like to invite Dr. Navin Thakkar, our secretary, to start the program and give us a welcome address.
Thank you. Thank you very much. Sorry, my face you are not able to see because my bandwidth is low with the mobile. But we are very much thankful for the Specialty Committee for arranging such a fantastic program under the leadership of Dr. Pachore sir and Rajkumar Natesan. And we welcome all the faculty and thanks a lot. Without wasting any much time, I request Dr. Rajkumar to start academic activities. Thank you, sir.
Yeah. Thank you, Dr. Secretary. Now I'd like to ask Dr. Pachore sir to just give a few words and kickstart the program.
Thank you all the faculty. This is a good initiation by IOA, which I just discussed right now, the specialty, and we are this time the Rajkumar has done a wonderful work of picking up the faculty, because we wanted actually the young generation of orthoplastic surgeon to they should have a platform, they should discuss, so that we are able to create actually a different environment. So I'm really thankful to Rajkumar for picking up this excellent faculty, and we will have a live discussion. And the main idea of this is to dissipate our knowledge, whatever we have, and discuss among ourselves and what is the best can be done for our patients. So without wasting, I think we should go ahead with the presentations and with a regular program.
Thank you, sir. Thank you for your kind words. For this today's evening, the theme is primary and complex primary knee arthroplasty, and we will try to discuss and bring out some good valid take-home message points on total knee arthroplasty, considering the primary and complex primary. The revision aspect, we will keep it as the next program. Today's program moderator will be our Dr. Dhiraj Marothi Jain, sir, from Vadodara, and Dr. Ahmedabad, sorry. Ahmedabad, sorry. And Dr. Indrajit Sardar will start with the symposium. Over to Dr. Dhiraj, please.
Good evening, everyone. First of all, I would like to thanks Dr. Rajkumar, Chairman of Subcommittee, and IOA President B Shivashankar, and Dr. Navin by Secretary. So I will invite symposium on primary total knee replacement by Dr. Indrajit Sardar. Over to you, sir.
Yeah, thank you, Dr. Marothi. We'll just start off with the. I'll just share my screen and then get on. Can you see?
Yes, sir.
Okay. Yeah. I just gone off for just a second. Yeah. So what we will be discussing today would be really basic stuff mainly, but points which have been under consideration and conflict and many opinions on various aspects of it. So let me start off this thing with the first one. Why template? Now, why template has many reasons. Why yes, why no? But the fact is that it was mainly done to predict the size of the practice processes. Now, I'd ask this question to all of the faculty. as to why you template. That's number one. And number two is, do you really template all your cases? Anyone can take it up. For example, yeah, Dr. Smarajit, Patnaik. Is he on?
Dr. Patnaik?
Unmute himself.
Sorry, I just muted myself. So templating is absolutely very, very essential in a primary totally arthroplasty. For that matter, any arthroplasty or any fracture surgery, because of the very fact that templating helps us to plan. And templating also helps us to say that what are the different aspects of preoperative planning we are able to do by using these templates. Now, the templates are available, and they are available with each company, and they are available for superimposition. And this always has to be compared with manual X-rays, considering the magnification factor. And it's important because to plan for any case which is a post-surgery case like high tibial osteotomy, if we require an offset stem, for example, for need of any sort of a stem extender, and this will be apparent during templating. And nowadays we are having a lot of digital templates, softwares are available, but there is a lot of study which suggests there is no great advantage of this digital templates compared to our manual templating.
So the question was, do you template all your cases or do you do it selectively?
We do it selectively, and not all the cases. Straightforward cases, not much of deformity, but routinely we take a hip knee ankle weight bearing scanogram, and there we see for the distal femur valgus cut angle what we have to take. And both the sagittal and the coronal plane deformities are assessed. Both the coronal and the sagittal plane deformities are assessed. And the sizing, it's usually like if there is any specific indication for that, or we are in a position where we have to plan for a constraint prosthesis, or in a situation we see an abnormally, unusually small femur, then only we, or any case with a fixed flexion deformity, then only we template those cases.
So a question to the rest of the panel, Dr. Shah, Ashit Shah.
Yes. Okay. So as far as templating is concerned, generally it used to be a good habit and we learned with the templates. However, you know, with the increased number of cases, the companies are providing us with all the sizes of the implants. Generally, I would agree with Dr. Smarajit that, you know, I don't primarily template all my cases for the sizing of the prosthesis, but what is more important is to get a scanogram so that we can draw the mechanical axis and then accordingly plan our axis, how much is going to be DFA, distal femoral valgus angle, the medial tibial, the tibial angle, and the mechanical axis of the tibia and the femur. So rather scanogram and drawing those lines, mechanical and anatomical axis are more important for considering a manual total knee replacement. That's standard we do here.
Do you consider a scanogram an absolute necessity in all the cases?
I do for all of them, and I draw the lines and make sure that, and there is a huge variation. Earlier, I was not very, I didn't bother much about the scanograms. And we just used to keep a standard 5-6 degree valgus angle for the distal femoral cut. And after doing scanograms for last 7-8 years, we know that there is a huge variation of, in a plain simple varus knee, there is a big variation of valgus angle, right from 4 degrees to 7, 8, 10 degrees at times. So if you were to remain stuck to 5-6 degrees of valgus, almost 20-30% of the times, your mechanical axis will not be appropriate.
So
and suppose we don't have a situation where we don't have a scanogram, then at least pelvis, X-ray pelvis with both hips, which shows us the valgus angle, the coxofemoral angle. I think that's very important, and the offset of the hip joint and any femoral bowing. So accordingly, we can plan our cuts.
Distal femoral cut.
Distal femoral cut.
Valgus. Yeah.
Yeah. So basically, we can conclude from this that a templating is essential, and that we would do a scanogram in almost all cases, even though scanograms are not available in many places, but at least a standing X-ray of both the knee joints in the AP position and in the lateral position. So fine, we'll go on to the next one.
Can I make a point here? If the scanogram is not available because all the hospitals may not have it, what you must do is take an X-ray of the knee centered with maximum of the femur and maximum of the tibia in one plate, or maybe take the X-ray plate oblique so that you have a longest diagonally, the longest diagon of that X-ray plate and the AP X-ray on that. So we'll have a maximum length of the distal femur and the proximal tibia, so as to have some idea of how much is the bowing. And that, along with the PBH X-ray, will tell us how much is going to be the neck shaft angle of the femur at the hip joint, and accordingly to change your valgus angle.
Right.
And along with that, the X-rays of the knee, the AP lateral, I think skyline or merchant's view also is equally important, especially in valgus knees, to see the patella positioning and osteophytes on the lateral compartment of the knee joints.
Sure. That's a very good point. Actually, skyline view should be made as a routine for all the cases. So it gives so much of information: how much of patella tilt, how much of patella subluxation, the lateral facet thinning, so much of osteophytes. So everything, so much of information you get it from the skyline view, and it will also help how much of lateral tightness is there perioperatively, how much of latrinocular tightness is there. All those things the skyline view gives. And also, to quickly add upon, the stress views also is very important preoperatively, particularly in a valgus situation. A stress view, without a stress view, it is very not at all correct to go inside and have some surprises. So better to have stress view so that we can see whether there is a bone loss, whether it is correctable or not correctable, partially correctable.
I think that's an important point, to see whether there is bone loss on one side or not, so you can be prepared with the stems and the possibility of grafts or something else. As regards size, I don't think it's very important, because now the companies give you all the sizes in a sterilized box, so you can see whatever that you need to do. And that's the reason why these papers came out at that time. And you can find out the defects on the tibial condyle by this doing the templating, or on the medial side, or you can do a size AP, or you can do a size lateral by seeing that the lateral condyle, which is a smaller condyle, and size it up properly. So all this helps in templating, and that's a useful thing to do before even a standard TKR. But then I suppose in the volume of cases that all of you do, there'll be areas in which you may not be able to do all that, but it's nice to target that should be done. Okay, the next question is the drains. So do all of you use drains?
No.
Yeah,
Drain last.
all of us.
Yeah.
All of us use drains.
No, I don't use drains.
No drain. No drain.
No drain.
Also.
Okay, one important point here I would like to suggest. It is for the surgeons who are young and not yet baptized into arthroplasty. Unless they are very meticulous in their closure techniques, it is safer to use a drain. Otherwise, they create a lot of problem in the sense that with the improper closure, there can be some gash shadows inside the knee joint. There have been hematoma in the knee joint. So that becomes a problem. So for the young and the uninitiated, they should learn at least either they put a drain, or they are very meticulous with their closure techniques, and they're before they finish off the case, the hemostasis, and then only they go for without drain.
Let us ask the other panelists also whether they.
Actually, if I may interject, I feel if you are using a tourniquet during the surgery and you are releasing the tourniquet after closure, then you probably need to put a drain. But if you are releasing the tourniquet and catching the bleeders, then it's a call based on the surgeon's choice. But what I do is I use the tourniquet throughout the procedure, do the closure, then release the tourniquet. So I always use a drain for 24 hours. And I feel that is probably ideal. If you're not using a tourniquet, you need to catch the bleeders before you close.
Okay, can I just add something? This, my first 5 years or so, every patient I had put the drain, and next 5 years I have not placed drain at all after the new evidence which suggests that it's not going to make much difference, especially with the tranexamic acid. We release tourniquet before closure and other things. In fact, about 400 cases we presented in our ISHK meeting. And in fact, my paper was the gold medal paper, which suggested it's very clearly, it makes no difference between the two. And also, there was slightly higher chance of transfusion, especially in bilaterals, if you keep a suction drain compared to the, the non-suction drain if you are using, but I think all of us are using the suction drain only. So we have stopped that practice completely. And I think, that is the evidence as well in a lot of literature, unless complicated revisions, a lot of synovectomy, bleeding dialysis and other things.
Same here as well.
I think
we don't use drains. There is no evidence for that. In fact, even for a straightforward revision, we have not been using. Me and my colleague, Dr. Santosh, we have done at least around 1,000 joints. We've not used drains, and we follow the rapid rehab protocols. All that the drain does is it pulls out the blood, and we haven't transfused for a primary TKR until today. Almost.
It was a bilateral study. It was, yeah.
Yours was a bilateral study, is it? Okay.
Yeah, there are questions regarding both sides.
But do you guys use the tourniquet or not?
We use the tourniquet.
Yes, we use tourniquets.
Yeah, but you release the tourniquet before closure or not really?
No.
No,
I don't
manage.
We just use Tranex, local Tranex, and that's it. And then kind of an RJ compression for a couple of days.
No, after the cement is set, I release the tourniquet in all patients for a couple of reasons. One, if there is any inadvertent bleeding, you can see. Second is that also in a vascular injury, for example, if you have a tourniquet release, it is very safe, and it hardly takes extra 2 minutes to see what is happening. And if your tourniquet is released, especially the lateral genicular vessel, etc., if you are not really cauterized, probably will have a lot of bleeding later.
Yeah, that's right. I would probably agree with you, Anand, because if you are not using a tourniquet, you need to catch the bleeders, especially the lateral genicular. It will bleed. You will have a bigger problem with the hematoma in the knee in the post-op. If you are not using a drain, my suggestion would be to cauterize the bleeders before you don't use the drain.
But one thing is also true, a lot of bleeding happens later in the post-operative period. You can't catch all of them after just releasing the tourniquet. Yes. But however, you see, whether you release it before or later, the drain has been almost, a lot of studies have come up now saying that, not much use, honestly.
So that is very important to understand that when we use drain, the tamponade effect that we get is lost. So all that drain does is basically whatever is getting collected, and because of the tamponade effect, it will stop the bleeding. That does not happen. So it is probably counterproductive, because as the studies have shown that if you use drain, then you have to have, there is increased number of blood transfusion even in primary knees. So moment you stop using the drain, be meticulous with your surgery, dissection, and use now the wonder drug called Trenexa for last so many years. I think the use of blood transfusion is minimized, and the drain probably is not necessary. All that as Ravikumar said, it does is when the patient starts mobilizing and the drain is there, it gets pulled off, and you honestly get a call at 9 in the evening that patient is bleeding, and that actually is bleeding from the drain which is pulled out partially.
And how many hours those who use the tourniquet drain will use it?
Pardon?
How many hours they will remove the drain after the surgery?
Okay, so someone who is using the drain. Yeah.
Is
Yeah,
somebody
we
using the tourniquet?
our protocol is
12 hours. I think what I do is, if I don't cauterize the bleeders, like if I put a tourniquet and I finish the surgery, closure, everything, and I do release the tourniquet in the end, I put a drain. So today morning surgery, tomorrow morning I remove it off.
24 hours, right?
yeah, our protocol. What we have observed is like, I mean, initially we went for drain, no drain, and all the thing. Now we have customized a bit. I mean, as in the anesthesia, whatever anesthesia, their blood pressure will be low, and immediately after the release of the tourniquet, we will not see the capillary or the ooze from the bone in the initial time. So when it picks up the blood pressure after they stabilize and they come out of the anesthesia by evening, so they may bleed a little bit. So this may cause tissue edema and decreased ROM or difficulty in initial rehabilitation. So we customized in this way, like we do under tourniquet, release the tourniquet as Dr. Narayan Hulse told, we especially the LIGA, lateral inferior genicular artery, coagulate that, and also few feeding vessels of the synovium in the suprapatellar area, coagulate them and observe for any major vessels in the center. Then local transient acid, put a drain and close it, and don't open the drain for first 6 hours. Anyway, that time blood pressure will be low, they won't bleed. And in the evening, open the drain. Next day, remove the drain. So this is, I mean, we are finding, I mean, transfusions are also not more because it will not bleed more. And also we are protected with whatever tissue edema it causes due to collection. So we are safe in both the way. We can, any major intraoperative bleeders can be caught, and also drain is there for 24 hours, and also it is planned for 6 hours. This is what we are customized after doing some small audit in the hospital. Yeah.
Yeah, right. So we are divided as the drains. Those who use a tourniquet would rather use a drain, but they would release the tourniquet. And those who do not use drains, they do it in their own way. I think we are still divided on this, but the older group would probably use drains. The younger group would probably not use drains.
So, but whatever may be, whether we use or if we use or not, better to remove the drain as early as possible,
Yes.
even if the drain is used. That should be the message.
That's the message. That's the message, Rajkumar. You're absolutely right.
Another thing I request to the faculty, don't repeat the same points again and again. So we will cover more the questions.
Yes.
Yes, I think that's another advice. Gap balancing versus measured dissection. Is this all theoretical, or do you really follow one at the exclusion of the other?
Dr. Samir.
Yeah, I usually do a hybrid technique. If there is a straightforward knee, usually do a measured dissection. If it's a severe varus or valgus, usually went for a mixer technique. Like some amount of varus will give in the femoral side to balance if it's a severe varus knee, like that. So basically, hybrid technique.
Any exclusive persons who use only one type?
Sorry?
Any persons who use only gap balancing or only measured dissection? Or everybody?
We use a mixture of both.
It has to be always a mixture of both, right? I'm not a fan of following only one protocol or one measure of, because it depends from patient to patient.
Yeah, I think it's not an either or situation. You do it as you, and if you look at it, we both start off with measured dissection probably and then go on to the gap balancing. Yeah, that's right. So that argument is really a bit theoretical. Stress fractures in extreme deformities. Would you use a TKR with intramedullary stems with unicortical plates? Would you use TKR with stems only? Or would you do the fracture fixation first, then wait for it to unite and do a subsequent TKR after the fracture?
So it's always TKR with intramedullary stems only.
So all depends upon where is the stress fracture, whether it is within the limits of the stems. If then definitely if it's a very proximal close to the joint, you can use a stem. If it's far away, either use a short stem and fix it with plates or screws.
Basically, the stress fracture is because of the deformity. So as long as we are not addressing to the deformity, this stress fracture also, even if you try to fix it, there's a high chance of it going to non-union or delayed union.
Anybody else?
So typically, fractures would need an intramedullary stem. Now, by definition, stress fracture would be generally stable fracture. It will not be displaced. It will be like a unicortical fracture. So it may not need most of the times a unicortical plate or anything. So if you have actually a traumatic fracture in an osteoarthritic, or maybe a patient who comes with a tibial fracture, but he has got a severe osteoarthritis of the knee, There, that's a different issue. That's a traumatic fracture. There, depending on the merits of the fracture, you to fix the fracture, which may be a separate plate, or you can do it with a total knee with a additional fixation of the plate. So that's a different traumatic fracture in an osteoarthritic knee. The stress fracture per se would be a stable, where probably if we can bypass that stress fracture lesion, at least couple of lengths. If you see the breadth of the tibia and multiply by 2, if you are able to go that much distally beyond the stress fracture and get the stability, you may do well just an intramedullary stem with the TKR.
Indrajit,
Yes.
one small suggestion: if you have a stress fracture quite below, do a fibulectomy also, because these fractures otherwise they go into non-union. Non-union. This is one of the mistake done by most of our orthoplastic surgeons. So be careful on this fracture. And the healing rate, once you correct the deformity, healing rate is extremely good, and you may not need a plate, additional plate. Very rarely you need additional plate. You should have a good fixation.
Yes, I think it's an
Sir,
important
my question to you, sir, the site of the fibulectomy.
Yeah, it is around 6 to 7 centimeter below the neck of the fibula, because you don't go higher, because otherwise you have popliteal and usually an FHL injury. So that is the reason you should not go higher up.
I presented the same case in ROC a couple of years back.
Yeah.
I think the fibula is a very important point, but sometimes you know that there's a stress fracture in the tibia and there's a stress fracture in the fibula. It's the same patient, both sides.
Yeah.
So how would you tackle which one? How? Only stem? Dr. Pachore's fibula has been done by the patient.
So
if you see on the right side, I mean, just in AP, we cannot see exactly where, but I understand right at the lower part of the X-ray, there would be a fracture. If you see in the lateral, it is going slightly towards hypertrophic non-union sort of appearance. I think so, it is quite away from where ideally we would be able to, hold it with a stem. But once we do a primary total knee, stem definitely would be necessary here, because patient would have some tibial medial defect, which will have to be reconstructed either with bone graft screws or an augment. I have a feeling that this may require a plate along with, on the right side I'm talking about, a plate to have the additional stability restored.
Yeah. If you don't get uncemented fixation, 2.5 cortical diameter below the fracture, it is always better to supplement with fixation. If you get that, I mean, no need of stem alone will help.
Yeah.
Quickly.
So this was what was done on one side, and you can see that this screw is a little bit too big, but we had to go on this way, that way, and but we got the stem. The reason was we used a stem is, look at the intermedullary canal. It was a very tight fit. The fibula is fractured. So we were able to get this thing on a pretty positioning. The other side, we did this, but here I will show you another thing which we did on the way. Yeah. That we used a temporary plate. We used a temporary unicortical plate because the fibula was fractured, so it's moving this way and that way. We used a temporary plate and then put in the stem and then remove the plate.
There is one more way when we can use a laminar spreader to stabilize that fracture. And that makes also, without putting a plate, we can stabilize the fracture by distracting the laminar spreader and then take all our cuts and then we do the intramedullary fixation. Again, that depends on the level of the stress fracture.
Yes. If you have already put the plate, we could have left it. Now, why did you remove the plate?
Because of the skin condition. The skin was not good, so if the plate was there, that would interfere with it. So we removed the plate and it is quite stable. Previous implant removal, same time as the total knee replacement, or you want to do it at an earlier stage or later stage?
Depends on the implant and...
Yes. Now there are some implants which will be difficult to remove, which will increase the more operative time, etc. There are some which you have to remove before you want to put in something. Would you want to do it at the same time as when you're doing the TKR? or you want to remove it, wait for some time, and then go on for the TKR.
If you feel that that implant which is there is going to come in the way of your tibial resection or femoral resection and putting your standard primary knee, those are the only implants you remove. If you can, by your standard primary dissection, I mean the cut of the soft tissues and exposing the bone, if the implant is visible, maybe extend it by a couple of inches, you can reach to that implant and remove that much portion of the implant, then better to avoid another incision. Important to know what implants are there, because sometimes this plating or plate screws have been done many years ago or somewhere else, not in your center. You may have to have those particular screwdrivers to remove the screw. That's difficulty that I always face practically, that something done 20, 30 years ago, 40 years ago, they have machine screws and those screwdrivers may not be available in our standard sets. So those kind of problems you have to anticipate when you see this implant.
Especially whenever the implant is an intramedullary implant in the femoral side, that's an important implant which necessarily has to be removed, because usually we use a intramedullary device for getting all our femoral cuts and alignments. So that is a kind of position where probably we have to remove the implant. We can do that in the same sitting or another sitting. That's not a problem, but implant removal there is more important.
With navigation, you can, avoid miss that point where you don't need to put an intramedullary, rod,
the patient
and then you can go ahead and remove only those implants which are actually, causing problems or on the way of seating the implant.
Yes.
And the most important thing is infection should be ruled out in any kind of implant, previous implant, because if there is infection, you need to do a 2-stage. So that is also a very important point.
That is most important.
If the implant is coming in the way of your surgery, or where your implant is seated, only I touch the implant. Otherwise, I don't remove any implants if it's not going to hamper your surgery.
Yeah.
Regarding this infection, we should have a high index of suspicion, because most of the time when the Indian implants are used, either because of a local metallosis or maybe a low-grade subclinical infection. Now, these things have to be very careful. We have to be very careful about the tissues which we are handling near the previous implant. I think infection is very important, which decides whether we do a single stage or a 2-stage implant removal and a joint.
Especially recently operated cases, there is a high chance of infections.
Yeah.
Yes. If you do it at the same setting.
Yes.
The other side was being operated. So at that time, we removed the screws, and then 4 or 5 days later, was it a week later, we went in and did the knee replacement. And when we removed the screws, we took a culture from the screw holes, and that all came out negative. So we were on safe grounds there.
Indrajit, you should keep one important lesson from all our orthoplastic surgeons is inventory of implant removal. We take it very lightly. Very lightly. So we need to actually know what is the implant. It should have a cutting instrument also. If there's a long plate, distal plate on the femur, you just cut the distal portion and get out instead of opening the whole of the femur. So I think that is another important thing which we should have in our inventory.
Right.
That's a very good point, because if you remove whole plate, then it increases the stress size and create post-operative periprosthetic fractures so many times.
Yes, there are weak spots there. Bone defects, we generally use the bone graft screw fixation stems, and sometimes with the less than 5 millimeter cement screw support and all that. And we know all this. So this was the graft which was put over here. And this was the whole extent of the defect over there. And this. The only thing I'd like to point out here, would you use this preliminary making the holes, making the position for the implants before or after the graft positioning? And in this, I would just add one point, is that the standard ones that we use is a Depuy one with the straight wings. But if you use an attune where it is going backwards, then it's a problem with these where to put in the screws.
I think, sir, all those cases where the keel is going into the defect, you must take implants which have a stem extender.
Yes.
That is the most important point. You might prepare the graft bed later on and fix the bone graft later, but you need to be careful that the keel has, if the keel has been prepared and it is going into the defect, it needs to be supplemented with a stem. That is the most important point, I think.
You can use short cemented stems for that.
Yes.
Yeah. Retain the patella. Patelloplasty better than patellar resurfacing? This debate has gone on for ages now, years on. So, who keeps the patella, who resurfaces it, and who retains it? Yes.
So, I have been Dr. Anawat's fellow, so we have been taught to replace the patella. So I have been.
I was about to tell that all ROC fellows in India will resurface and non-ROC fellows will not resurface.
Yes.
No, that is not true. That is not true.
So Indian arthroplasty has a lot of influence from Busireddy and Ashok Rajgopal. So many people will not, resurface the patella. I think so. The way is to, first of all, it's important to know how is the tracking, rather than whether it's grade 2, grade 3 arthritis in the patellofemoral joint. That's probably not so important. It is important to track the patella properly into the trochlear notch of the implant. So that is the first and foremost thing. Once you have done your basic cuts of femur, tibia, and you got the rotation right, and if your patella tracking is fine, then perhaps you can, depending on the thickness of the patella, because many of our patients are short. They are hardly 4'8", 4'9", 4'11" height women. They have a short, small patella, and then you start resecting, and we may encroach into the minimum depth of the patella to be retained. So in those cases, once you have the proper tracking, you can just do a patelloplasty and leave those patients. However, when you have a thick patella, and then you may select to resurface the patella, that is entirely surgeon's choice. But either ways, if your tracking is good, then either with the PS knee or with the cruciate retaining knee, the patella will be okay. I know all PS surgeons, even I'm a PS surgeon, we all have been taught to replace the patella when you are doing a PS knee with a particular PFC sigma, which has got a large box. But the newer designs of the same company and the other implants, they have a smaller box, so you can probably get away without replacing a patella, even if you are doing a PS knee.
A couple of points. I have not been a Renault fellow, but I replace all patellas. That's one thing. And second thing is, it's been shown in multiple studies, you will not be able to select which patella to resurface, which not, by looking at the cartilage. Whether you are a selective resurfacer or non-selective resurfacer, whatever, you will not be able to decide just looking at the cartilage. So it is not possible. Third thing is about this tracking of patella. Now, whether you resurface or not, we always have to make it really track well. So again, it really doesn't matter whether you resurface or not. But one thing we can do, if the patella is not tracking well, if you use a smaller size of button for the patella, for example, you can bring it little medial, little superior, for example, in case if you have a patella baja, etc. So by resurfacing patella, you can actually improve the patella tracking if you want to do. Now we have a lot small patellas, etc. But I never had such problem, in terms of resurfacing patella, even though we have a smaller size, etc. But I think, all of us are patella resurfacing. None of us have these, the buttons which goes into the patella. I don't think anybody is doing in the country at the moment. But
inlay, you mean inlay buttons?
Yeah, inlay buttons.
So we all use the the onlay button.
Yeah.
So I don't think so. Any of the systems are available which allows.
I am not an ROC fellow, but I replace all my patellas.
Same as you.
There are medical and non-medical reasons also. Non-medical being, when I tell a patient a total knee replacement, I have had a couple initially when I didn't replace. They had some sort of vague pains here and there, and some of our own fellows tell because you have not replaced the patella, you are getting it, so they should have done it. So that also is one of the reasons which I consider, in addition to all the medical reasons we can discuss pros and cons here. But I feel, and in the US when I went and I was with David Fisher for some time, he said one of the reasons he replaces is none of this, because he gets extra money for replacing patella. If he doesn't get that extra money.
But we don't get.
Yeah, so so there are a lot of reasons to replace patella or not, but for whatever reasons, I am replacing all of them.
Yeah.
I think so. In 2019-ish in Bangalore, I think so. There was a statement that we took, if Dr. Pachore remembers, that all these controversies were voted by each and every member. Sir, Dr. Pachore, would you? I think so. This was one of the question in that, and so legal part is taken care of in that, as far as I understand. So that's not a big issue for us.
It is actually not the legal part in the court as such. It is just the difficulty in explaining these patients, who come back with little pain. If you have already done a patella, you can tell them, it's just a muscular pain or myalgia. Otherwise, your competitor will tell you it's because you have not resurfaced patella.
Actually, what if that myalgia doesn't go? That anterior knee pain
more
is
than the
totally
medical
different.
terminologies, this becomes a bigger headache.
Yeah.
Explaining to the patient, even the courts also, it's difficult to explain to them the medical terminology, sir. So the person who is a judge may not necessarily be a very educated and soft person for you. So I think a lot of factors in addition to the medical reasons why I replaced.
But I think the two things, I don't know, I'll ask Dr. Pachore as well. Couple of things are very important here. One is if you are resurfacing patella, as we all do, there is definitely higher chance of patella fracture. Obviously, you have one extra added procedure with extra complications, which is true. Whereas in almost all large studies, if the patella is not resurfaced, they do have a higher anterior pain. Whatever the definition of the anterior pain may be, it is difficult sometimes to define that, but a lot of studies have shown that. What do you think, sir?
Yeah, let me come to that now. If you look at this controversy is never going to end, because we even though there are a lot of prospective random going on, but one thing is very important now, because old time we didn't had a femur which was friendly with the trochlea.
Yeah.
Today the designs have changed. It has made a lot of difference. And secondly, the Clunk syndrome, whether you replace patella or not replace patella, there's a minor difference. So why many people like to do the patella replacement, according to Ranawat, whatever now Ranawat fellows we are already discussed, that there is if you consider 98% of the 98% is the what you call as a satisfaction rate of a patella patient who is replaced. And those patients who are not replaced, it is 95 or 2 or 3% difference. That is the quoting Dr. Anawat had. So if you look at our own data of age of 2 lakh joints, let me come to that. The people who are using a PFC, the 78 to 80% are replacing patella. And if you look at the femur, there are only 25 to 28% people are using patella replacement. So that is the difference which we have. And in general, of 2,50,000 joints, 50% of the surgeons are using, and 50% are not using. So that is the data we have today.
So my question is that is it really related to implant then? What do you?
It was a training and it was initially related to the implant. There is no question about it.
No, but last decade that implant design is quite changed and now there is no issue in patella.
Yes, that is the reason. If you look at the 5 years back data, PFC had 95% surgeons were replacing, but they have now reduced to 78%.
No,
I have published this.
Cost of the patella.
No, I don't think.
No. The cost of the patella.
Complications.
I think it is the anterior knee pain has reduced because of patella replacement, especially with the implants like the Attune. So I published a paper with Dr. Nawat and Dr. Amar on this, where there studies on Attune, which says that anterior knee pain and Clunk is less than with the Attune knees.
Those studies are called originator studies, you see.
And also,
but in Attune, if you see, they have
had a couple of cases where there was a patella fracture, and as Narayan told, once there is a patella fracture, it is very difficult. And one of the case, it went into non-union. We did everything, but it wouldn't heal. So you can imagine. So if you see, there is no strong evidence to state that you replace and the outcome is good. So I think if your design is patella friendly, then I don't think we should go and do the patella resurfacing. because most of our patients are elderly and they're osteoporotic. So I think we should think twice before resurfacing.
Yeah, I think
and
Dr.
one of the other
Bas,
causes what we note for the anterior knee pain is the medial saphenous nerve neuroma. So it's a very, we see a lot of those. So,
yeah. Finally, I think the time is running out, so I'll finish off with this case. This is a 60-year-old female, bilateral stiff, painful knee, gradually increasing for the last 5 years, with ROM of only 20 to 40 degree, walking distance 5 to 10 meters, spine pain, stiffness and tenderness, diffuse pain in tibia and femur, and there's no neurovascular deficit. This was the X-ray. Would you point out anything in it which you find different or special?
Is it Paget's or osteopetrosis?
Some metabolic bone disease, yeah.
Yeah, metabolic bone disease, maybe.
All her other endocrinological investigations were normal. And as we normally do, we did, this was what the tibia looked like. And if we don't have a diagnosis, look at the spine. Any comments?
Fluorosis.
Yeah, this is actually an osteopetrosis, which came out to this level. Now, osteopetrosis, now, if you go back to the original femur, you can see the diminished medullary canal. So an intramedullary rod was out. So we had to think about something else, something of a patient-friendly thing. And we used this, which is, I think you're all familiar with this. This is the Arthro 3D, where they do a city-based block calculations and then do this for the different companies. They have different, all of these implants. You don't use an intra or extramedullary rod. And we had to be very careful with the drilling part of it. We couldn't use the standard ones, but femur didn't require a drilling because we had this. And on the tibia side, we did the drilling with increasing size of drills. And then the slots that were made for the keel were drilled with saws first to get the defects, and then done the central plates. So this was what it looked like. Sorry. Oh, no. So this was what it looked like after this was done. This seemed to be another X-ray, I think. Anyway.
Yeah. This looks like a different patient.
No, go back. There is one more X-ray there. I think.
But
go back.
These patients, this osteopetrosis case was very new for us because when I investigated, I found there are only 50 odd cases in the entire world repeated. So now this patient is about 6 months follow-up. She's fine. She's walking. She's climbing stairs. She's doing everything. She complains of diffuse pain of the spine, but I just thought I'd present it to you to show it to you of this nature. I think we are exactly at 6:45. Can I, shall I stop right now?
Because even Dr. Sardar has not changed the patella. So that
yeah, that's what I wanted to tell you.
You are lucky that you went, that osteopetrosis is a very, very difficult condition actually.
Yes, yes.
You are very lucky that you were able to at least drill it. I think you have to keep in mind, you have to use a carbide drills for these patients. Carbide drills, they work beautifully because we did some fracture work initially, maybe 20 years back when my boss was alive. So that time we used to get a carbide drill from the Lohar Chal actually. So I think the osteopetrosis and fluorosis, there slight differences there. In fluorosis, you will see some bone available. Number two, the calcification is there in the spine. In fluorosis, well, we will not get a calcification in osteopetrosis. There are certain difference. And if you take pelvis X-ray, you will have ligamentous calcification in fluorosis, and which will be absent in osteopetrosis. That is the difference we have.
And also, sir, in osteopetrosis, this cortico-medullary differentiation is not there. It becomes like a single mass.
Yeah, the bone is not seen at all.
And also, the X-ray, what has been shown as a post-op, I think it just mixed up, sir. What you're showing now is the correct X-ray.
Now it is put right X-ray now.
Yeah.
This is the one.
This is the one.
This is the one.
This is definitely osteopetrosis.
Yeah.
and he is very lucky, very rare to, I'm not seen knee.
And in this X-ray, if you see on the tibial side, you have not put the extension rod, which is difficult to put because of the drilling issues.
Yes.
Yeah.
You can't.
One last question. Pachari sir, one question, sir, from my side.
Yeah.
So you resurface the patella and they come back with the anterior knee pain.
See, anterior knee pain is a big thing. We really don't know. There are about, I think, almost 6 to 8% and maybe more patients have anterior knee pain, and it's very sometimes difficult. Suppose those patients who are not replaced by my colleague, and I say that your colleague has not replaced, and I will do it. And if you do it, 50% patients are again continue to anterior knee pain. So really, we don't know. It's a big problem for anterior knee pain.
I think main topic of discussion then was that if you do not replace the patella and then the patient comes with anterior knee pain, there's 12% of patients who, if you replace it, don't get the same results as Dr. Pachore was saying, as you have done had you done it originally. So that was a paper, and that's what brought about this discussion throughout. So Rajkumar, shall I, Dr. Marothi, shall I sign off now? I think
we can go ahead with the second session.
Yes. Thank you. Thank you so much. Thank you to the panel. Thank you, everybody. I think we've had a lively discussion, and I enjoyed it.
Thank you.
Thank you, Dr. Indrajit.
Thank you, sir.
Thank you, everyone. Very nice presentation, and we have discussed all the points, starting from virus and defects and osteopetrosis and all the things. Now we can move for the second session. In between, any discussion or?
We'll go ahead with the second session. We can discuss during the cases.
So I will invite directly first speaker, Dr. Anand Srinivasan. Dr. Srinivasan.
Good evening, sir.
He is speaking on osteo.
No, he is presenting a case. He is presenting a case.
Okay. Sorry. He is presenting the case. Sorry.
Please share your screen.
Please share. So time remain. It's a 5 to 6 minute presentation and 2 to 3 minutes discussion. Total time is 8 minutes for each presenter.
Good evening to all. Thank you for the opportunity to present my case. I'm a very young student. So my name is Dr. Anand Srinivasan. I'm from Chennai. So straight away going to the case. So 62-year-old male who presented with pain and deformity over both knees for the past 15 years. So gradually increasing in intensity. And the pain was more for the past 5 years. He was a known case of CML, which is a known leukemic patient for which he took treatment 10 years back. So during that time, he had restricted mobility, following which his deformity started increasing. And he's also a known case of diabetes, hypothyroidism, and hypertension, for which he was taking treatment. So it's irregular in treatment, and pain. He was having more pain over the right knee than the left knee. So on taking the X-ray, so on seeing the X-ray, the deformity was more on the left knee than the right knee, but his pain was more on the right knee. It was more symptomatic for him. It's a standing AP view and it's a lateral view. So just to be sure, we also evaluated his hip joint and spines to check whether there were any deformities over in that region also. And then on examination, patient had a fixed flexion deformity of 30 degrees in both knees, and the further range of motion was only from 30 degrees. He was able to only flex up more of 30 more degrees, so 30 to 60. And he didn't have any neurological deficit, is recorded, and his gait was crouching type of gait. So he was walking like this. So his feet was not touching the ground, his heel was not touching the ground. And this was his walking posture, but like crouching gait.
Okay. Who will take this case? Panel? Dr. Ashit is there?
Yes, I am there. Okay. So just is he
Anand, go back to the X-ray. Show the X-ray. Yes.
Just one thing, is he rheumatoid at all?
No, sir. No,
He's not
sir.
a rheumatoid. Okay.
No, sir. No, sir.
So this we take it as a 30-degree fixed flexion deformity, and you said right side is more painful. Obviously, we need to perform the surgery. Few things preoperatively you have to keep ready is okay, fine, your standard implants, primary knee with primary implants, we should be able to manage this. However, you should have an additional constraint also on your shelf, because this is something that you may find a flexion extension mismatch in this, with flexion gap being looser as compared to extension gap. So that's something that you have to keep in mind. Extreme osteoporosis, so you keep stems ready, not necessarily that you may have to use them. Now, when you are doing one knee, right knee, obviously under anesthesia, probably this will stretch out a little bit. So, whatever your pre-op deformity of 30-degree may actually be about 15 to 20 degrees because of pain and spasm in the anesthesia. It probably will relieve some of that, right? Then standard approach, as you do either middle parapatellar or subvastus or midvastus, expose the femur, and when you take the distal femoral cut, normally just take as much as necessary as the thickness of the femoral implant. Distal femoral. Do the proximal tibial cut. Mark those distal holes in the femur, and then do an AP cut of the femur. Now, don't do the chamfers, don't do the box, but start working on the posterior aspect of the femur. There are osteophytes, posterior ledge of the femoral condyle, and the soft tissue release. Slowly with an osteotome or slowly with the curved osteotome, and strip the posterior soft tissues. Then start slowly, it will open up the extension space. So this is where you put the spacer block in flexion, and then gradually try to get that into extension. Very, very, very judiciously, you may choose to resect extra millimeter of femur. But again, I told you, first is minimal resection, and then do the soft tissue release, which is at the back of the femur. Flexion deformity, you have to handle it with, clearance of the posterior aspect of the femur and try and match the balance. So once you have your flexion and extension balance, then you can do your notch, the complete rest of the surgery.
So in this
post-operatively, patient may remain in about 5 degrees of flexion deformity. If it is an osteoarthritic in a male, don't accept that. You have to get the knee straight. Patients have to be in the brace. All these patients who have long-standing flexion deformity will tend to put a pillow at the popliteal fossa, which is again a big no-no. So try to make sure that when you take around or your residents take around, the knee is straight, or put a pillow at the heel level, so that with the weight of the knee will go in extension. The splint has to be on, except for when they are doing at the edge of the bed and range of movement exercises. They must walk with the splint. They must have the night splint to be removed only when they are doing range of movement.
Dr. Srinivasan, what you did?
As Sir said, first before going to the patient, we counsel them what would be the realistic expectations.
That's okay. What you did?
Yes, sir. We almost did similar process, standard anterior approach and with for medial parapatellar, and I was not even able to dislocate the patella or slide the patella because it was very chunky, very bulky. So first I had to the osteotome slightly cut with the patella and then debulk the patella first before going in, and then only I was able to proceed with. As sir told, remove the osteophytes first in the anteriorly, anterior margins, then went for a distal femur cut, slowly releasing all the soft tissues as and when required, and removing the osteophytes posteriorly. A posterior capsule release also we did. Then as a standard 9 mm cut was first taken, but on checking out after the tibial cut, I was not able to achieve the full extension. So again went back, I marked the pins, I didn't remove the pins, the pin was there. So again went back and take another 2 mm cuts, and then went in and again released all the posterior capsule, and again released the posterior capsule from the tibial side also a little bit, so that I was able to achieve some good degree of extension. I had a doubt whether able to do it in the both in the same stage or in the staged manner. Whether to do it at the same time or with staged manner, sir. So what we did was for staged manner. So suppose stop me for right side. And 2 weeks later, yes, sir.
Any comment on this lateral X-ray?
I'll come. It's a notching. It's the femoral notching is there.
Yeah.
I'll accept that.
Thank you. Nicely. So we can proceed for the.
One point to add. Yeah.
Yes. Yes, Ravi.
Yeah, the point to add is here, we have to divide the fixed flexion deformity two categories. One fixed flexion deformity with good range. Okay. So then their life will be little easy. One fixed flexion deformity with limited range. They're going to stiffening. They have both the approaches and ornamentarium needed for approaching a stiffening and also a fixed flexion deformity. In such cases, we need to have a semi-constant as a backup with stiffening, FFD with stiffening. It's must.
Just one small points I wanted to add. I've done that in a couple of cases.
Please go ahead.
There's something called as a 1/3, 1/3, 1/3 rule. Now there are some, the TKRs, they have, the knees have flexion deformity so bad, something like a 90 degrees. It's almost so difficult, even if you make the distal femur completely bare, you cannot correct them on the table. It's very difficult. And you have to use the hinge, etc. So this one of the study which they have done, which I have used in a couple of rheumatoids with a severe deformity, is you do a serial plaster of these patients pre-operatively, and you get about 1/3 corrected before surgery. And on table, don't try to correct it fully. You leave some degrees and then put the serial plaster later on as well, post-operatively as well. And we always worry that whether we get the movement, etc. They all get reasonable movement, and they all have been shown to be reasonably good even with the plaster correction. And I was surprised before I was trying this, but it looks, works very well.
But that is good for an inflammatory condition.
Yeah, rheumatoids usually.
But in this situation, it is like if it is a primary ONE, the challenge is to get the things done on table. So here the whole point here is it's well done. The thing is, you should not try to downsize the femur so much because your flexion gap balancing will become difficult. So probably we don't know perioperatively, but here looking at the notching here, probably he could have gone one size bigger and got away with the flexion tightness and try to release as much as possible. The more distal cut you take, then becomes the flexion instability. So the whole school of thought is always take more distal femur cut whenever there is a gross flexion deformity. But nowadays with the modern implants, we need not do that. We get all the corrections by soft tissue release and try to keep the bone cuts as minimal as possible. In fact, you can even go by taking a 0-degree slope jig also in these kind of situations where you won't have so much of flexion problem. So try to go by that, do good release. Don't try to downsize so much, and then get the correction on table. And as correctly said, if it is a male patient, obese, on table, 0 degrees should be achieved. Otherwise, again, it will go into flexion deformity.
Rajkumar, I'll add only one point.
Yeah.
Here, in flexion deformity, flexion deformity, extension is tight and flexion will be loose conventionally if they have a good range.
Yes.
Okay, so that you have to decrease the slope and whatever, downsize. And in flexion deformity with stiff knee, both will be tight. That's why probably he is downsized to increase the flexion gap. If you ask him, please ask him. I think that's why it is notched here.
Yes, sir. I had to cut again for 2 months, then to increase. It was tight in both flexion and extension, sir.
Your flexion gap was also tight, no, doctor?
Yes, sir. Yes, sir. It was very tight. It was very plastered in. It was fully plastered in, sir. So very.
That's why you have to differentiate between the stiff knee with FFD and without FFD, because I had the vast series we have done here in our hospital. So that's what I checked. If there is whatever FFD is there, let it be there. We can go for constantly and correct it. If FFD with stiff knee, you will have challenges like this. Surprising challenges.
You should stick in the time. So I will request, please start the presentation, and I will request next presenter, Dr. Ravi Kelkar. from Bangalore. Thank you. So nice. Good presentation. Thank
Anand, you have to log off. It's telling I can't share the screen when you're.
Sir, I am cut off. Yes, sir.
You have to stop the screen
You have to
share.
remove the screen. Yeah.
Thank you.
You're able to see?
Not yet.
Not yet.
Can I add something, Dr.
Yeah,
Rajkumar?
please. Yeah, Mrinal.
So I have given a new classification of stiff knees, which is published online, and it's coming in the August issue of Indian Orthopedic Association, IGO, Indian Journal of Orthopedics. So I have classified based upon my experience into 3 times: stiff knees in flexion, stiff in extension, and those ankylosed knees in flexion and extension. So there's a different criteria and different way to approach all of these, which I think our viewers should read that paper. In-depth details of those are given in that.
Very good, very good.
Nice, Mrinal.
Thank you, sir.
You're able to see?
Yeah. Please go ahead. Please go ahead.
So, hi, good evening, everybody. I'm Dr. Ravi Kelkar from Bangalore. So, today I'll be presenting.
Dr. Ravi, can you please go to the slide mode, slideshow mode?
Full screen.
Okay. Click on.
Yeah, thank you.
Yep.
Yes, please go ahead.
Yeah. So we are going to be talking about complex primary knee here. So I have a case who's a 64-year-old male. So he has knee pain since many years, but last 2 years pain has increased and he has difficulty in walking short distances. The knee range of movement is 10 to 80 and painful. The only comorbids is he has hypertension and he's on Telma 40. Otherwise, he's pretty okay, no major comorbids. So this is how he is in terms of the deformity and the problem that he has. So obviously you can see there is a significant varus with arthritis, and then that is the X-ray. That is the AP view of the right, and then that's the AP view of the left. And that is the lateral view. So I would open up the discussion and then you guys can comment and then we'll take it from there.
Yes, Mrinal.
Pre-op.
So
the left side, you can concentrate on the left side.
Okay, so we see here it's a varus with a bone defect, and it's a long-standing varus, and it's a correctable varus. So the most important thing is we need to take care of 3 things. One is that you don't need to cut a lot of tibia because it's already correcting on the stress views. And also we have to build up the defect. That defect is almost of the medial tibial condyle, almost more than 40-50%. So I have published a paper in Indian Journal of Orthopedics in 2013, where I have published 54 cases of such kinds, where we have built up the defect using bone grafts and augmented with the stems. If the defect is more than 50% of the medial tibial condyle and it's almost going up more than 10 millimeters in depth, then you might need to use a mesh and impaction grafting in such situations, or you can build up those defects using large metal augments. And sometimes you might need to use, if it's going beyond 15 centimeters, you might need to use a sleeve or a constrained implant in such situations. But in this case, probably I'll be able to manage the defect with bone graft from the chamfers, use a stem extender, and with the minimal, obviously, tibial cut. So that's my take on this.
So you will take both the case simultaneously or one by one?
I have done both together in a lot of cases, so I'll do both together.
Okay, and same plan for the right side as well?
Yes.
Dr. Samir, your approach?
Yeah, basically the left side is a little more straightforward. Only thing what I need to be taking care of the medial defect, for which I usually prefer today. Definitely there is a stem is needed, and depending upon the quality of the bone, I might prefer a bone graft or even a wedge will be as a backup. But definitely on the right side, I have a backup of constraint. Definitely will be a semi-constrained liners, at least should be there in my backup. Because that,
yeah, quickly to add, if you're going to use a bone graft, can you explain exactly what bone graft and what you will be doing it with the bone graft?
Yeah, especially we take from the box. If you are using a navigation, we'll get a good box without any holes. Especially we are referring to the PS knee, so we'll get a good box knee. And preferably we'll make the vertical cuts a little more laterally so that we'll get a step cut. So the graft will become more stable and temporarily fixed with the K-wire. And then the keel will be prepared on the keel in situ, fix it with screws. And definitely will be augmented with the stumps.
I think you use the technique, I use the technique by Windsor et al. And also given by Dr. Anawat and others, where they have actually used the distal femur and the proximal tibial bone cuts, the bone from there. And once you prepared the keel, you prepared the bone bed, you use that graft. In Sancheti, they use a step cut technique, but I usually raw the graft in an oblique fashion, put in the graft, stabilize with wires, then put in the screws, and then see to it that the keel preparation is also good, and then augment it with stems. If the patient is affording, you can use augments, obviously.
So as what you did in post-op.
Yeah, so I think the reason I put this is because sometimes what happens, the X-ray will show a lot more abnormality than when you actually open up. It might not necessarily be the same, especially with the left side. If you see, looks like the whole tibial condyle on one side, especially the medial side, is gone. So this is the side view. So the points what I thought we'll consider pre-op is whether we are going to do unilateral or bilateral surgery in the same sitting. Since there is a severe varus deformity, how are you going to correct that? And then bone loss medially on both sides. So obviously, like we discussed, graft, wedges or augments, and whether we are going to use constrained or non-constrained. So I would always keep some constrained implant as a backup. The idea will be to avoid it as much as possible. So these are the points which I took into consideration pre-op. So in terms of the considerations, yeah, so severe varus, both knees, patient was fit and well. And so I decided for both knee surgery because the severity was so much, he is hardly able to walk short distances. So if we do one and then try to do the other one, obviously there'll be mobility issues and the patient is fit and well. So I thought a bilateral knee surgery will probably be a good idea here. And obviously the varus was fixed with an FFD, but we was able to get full correction. And obviously we follow the basic techniques of gap balancing, pie crusting, removal of all the osteophytes, medial soft tissues I released in a very graded manner because we don't want to release too much and lead to some sort of MCL instability. Now the right sided, obviously the defect was an uncontained one, but it was around 8 to 10 millimeters. So I used a bone graft with a screw for the medial plateau and a long stem. The left side, it was contained and it was around 10 millimeters. So I was able to get away without a stem or a graft. So what I did was I used this technique of a little bit of lateralizing of the tibial plateau and cementation. And then there are a lot of studies where they have shown that if you can get away without a stem and a constrained implant, it's always better. There are a lot of studies where they show you can downsize it a little bit, be a little more lateral. That will be good enough if you can get away with it. So these are the points which I took into consideration. And then this is the post-op X-ray. That's the right side, and then that's the left side. So that's what I was talking about. So if you can see, I was able to fill that up, get some good back, and then lateralize just a bit. That's the AP view. And for the right side, I had to use a graft and then a stem. And then that's the lateral view. And that's the patient day 7 post-op. So he is able to do full knee range of movement and the deformity is corrected fully. Thank you.
Thank you.
I have a point to make here. If you are putting in a graft and you're mobilizing the patient immediately post-operatively, you need to put in a stem extender because otherwise the graft will go into a varus collapse because it will the blood supply to the graft will take a while to get back, and till that time, there can be fragmentation and or non-union of the graft. So it needs to be protected.
So also one more just to add upon, whenever we are planning for a graft, the bed has to be prepared properly.
Yes.
And majority of the time, the medial side will be a sclerosed bone. And the more you start preparing, you will be trying and getting a big defect. So you sometimes suddenly you will see that your graft will not be sufficient enough to go for a screw fixation. Then you might go for a metal augment for such a situation. So whenever we are preparing the bed, you have to have a backup of an augment or sometimes even a sleeve, which may not be that common, but still as a backup.
Thank you.
Yeah.
Thank you, Dr. Ravi. Can you stop the sharing?
Yeah.
So next speaker is Dr. M. Manoharan from Pondicherry.
Good evening, sir.
Puducherry, sorry.
Yeah, Puducherry. Yeah, Pondicherry also fine, sir. Good evening, sir.
Please.
Is it my screen is visible, sir?
Yes, yes.
Yes, sir. Okay, sir. Actually, in my system, my video is not working, so I'm just presenting without video, sir. Maybe my phone it is showing my video, sir. Am I audible, sir?
Yes. Very much, very clear. Please go ahead.
Yes, sir. Straight away, I will go to the case. I would like to thank all the organizing panel for giving this opportunity. So this is my case. Is it moving, sir? No. Yeah.
Yes.
Yes, sir. 55-year-old gentleman with the controlled diabetic who had a complaining of pain, swelling, deformity of right knee for 5 years duration, and patient had a neck of femur fracture 2 years before in the same limb, and for which hemiarthroplasty was done elsewhere, and he was able to manage for another quite 2 years, and patient had a swelling and pain got aggravated for the last 1 year, and as well as difficulty in walking and activities of daily living. On examination, right lower limb, hip showed the healed surgical scar without signs of any infection. Diffuse swelling present over the entire knee joint with the gross patellar tab positive. Valgus deformity of 20° present, which is not correctable, and fixed flexion deformity of 15° present. Further range of movement is only up to 80 degrees present. MCL is intact. There is no medial laxity. The extensive synovial thickening noted on the medial aspect of the knee joint. So this is the clinical picture as a walking video, and patient was almost walking with a stiff valgus with shortening. Shortening will be probably due to the hip hemiarthroplasty.
Shortening and lengthening.
Yeah. So this is the X-ray. Sorry for the I'm not able to get the full length X-ray. I'm not able to recollect the pictures from my gallery. So this is the X-ray available. And hemiarthroplasty side, they have cut more neck, so that I think that will give the information that for the shortening. This is the X-ray, sir, preoperative X-ray. Can I proceed, sir? We'll wait for the discussion, sir.
So
just wait.
Wait for a minute. So definitely, its case is open for the discussion. Who will take the case? Dr. Hulse, Dr. Narayan.
Yeah, so this is a fixed valgus and a moderate degree, and the hemiarthroplasty which has been done on a proximal femur, which we have to be careful only in terms of passing the intramedullary rod while cutting the distal femur. Otherwise, I have no other issue. And if you want, you can use a navigation or an extramedullary system if you want to use, or you can use a short rod, if it's going to be appropriate. So my plan is.
Have you required merchant view in this case or not?
Yeah, merchant view will help, in terms of especially the valgus knee. It will help for the lateral contracture and lateral tilt of the patella. Now, the important things to underline here in this case, kind of cases in valgus is, whether it's correctable or not clinically, and then the surgical approach. And a lot has been discussed about the lateral approach, but I go with a normal standard approach which I normally do every day, which is the medial parapatellar. Distal femur cut, normal cut, but I will not, cut the lateral condyle, which looks like hypoplastic. And I also have to be very careful in terms of my rotation, because the posterior lateral condyle will be hypoplastic. And on the tibial side, I make sure that I don't cut too much tibia on my first time when I'm going to cut, but otherwise it's going to be a standard extramedullary jig cut. Take a lesser cut with about maybe 2 millimeters on the lateral side if you have a lateral defect, which usually happens on the posterolateral aspect. After that, I put my spacer and get the lateral release as much needed sequentially from anterior to posteriorly. That's what usually I do. And, this looks like a standard implant and a standard technique. We should be able to do that.
Yes, Ashit.
And before you make a distal femoral cut, make sure that you take into consideration the remodeling of the distal femur. See, if you see the distal femur in the AP view, there is a remodeling of that at the metaphyseal diaphyseal junction. So you may have to reduce your valgus, distal femoral valgus angle. So standard is what we take is about 5-6 degrees. Here you may have to take either 3 or 4 degrees depending on your calculation.
Yeah.
Can I just, Dhiraj?
Yeah, please, sir.
I think we have to learn a lesson that every valgus knee, please take the skyline view. That is absolutely a must. We must pass this message to all the surgeons. Reason is, you will know what is happening to the lateral patellofemoral arthritis. So one important message from that X-ray is, if the patella is subluxated or dislocated, your medial approach is not going to be easy. So actually, that is the patient. You need to do a lateral approach, cablish approach, and it is not that difficult because we are afraid. That's why. That is the problem. Number two, very important to take the stress X-ray of these patients. How do you know it is a fixed? Unless you know the stress X-ray, what is the amount of correction? Because once you give a stress X-ray, you will know how it is amount of opening, and you will also see configuration of the lateral condyle so that you can reduce the valgus angle. What Ashit was telling, that is another important thing. And under anesthesia, please examine these patients. Just don't go and just do a approach. You examine as a surgeon and see how much amount of correction he is getting, because most of these valgus will get corrected once you give anesthesia. That is very important for us. And with a fixed flexion and valgus and a fixed rigidity and a patella subluxating, I think best approach is lateral approach.
So that's the point well taken. So that's why I asked that emergency use must, if any valgus knee, if surgeon
Absolutely.
Thank you. What you did?
Sir, this is how I have done some planning, sir. This is how I measured. So I have found that preoperatively there is not only the lateral tibial condyle depression, almost like a medial condyle also has some defect, and there is a huge medial osteophyte which is seeing under the MCL. So that may be the threat for the MCL integrity. And this is how I analyze the lateral view. So in lateral view, this is the lateral condyle. It is so much like a cup and saucer. This is the medial condyle defect. So with this, any fixed valgus deformity, these are the problems will be there. Asymmetric instability with bone defect. Yes, sir. I will proceed. Yes. So these are my problems in this case. Stem is inside the femur. So intramuralgic, I used a short stem and partially correctable valgus with intact MCL. So it was intraoperatively partially correctable. Then tibial bone defect on both sides. Coming to the approach, I used a standard medial parapatellar approach, and it will be a challenge will be there with the rotation of femoral component, and order of release also we have to be very careful. And this is how I proceeded. And this is the intraoperative finding. So while doing because it was only giving up to 80-degree flexion, my knee joint, that patellar tendon was started healing up. So I put a additional pin to protect it. Then I have cut the minimal tibial cut, and it was shown with contained defect on the lateral condyle as well as uncontained defect in the medial condyle. So it was less than 5 millimeter. So I managed with lateral bicresting of the LCL as well as TFL. Then managed with standard PFC sigma with the tibial stem extension and 10 size inserts. And during this, actually one mistake was happened as it is automatically releasing tourniquet. So suddenly it started released during my cementation. So I was not able to have the control. So that is why I think it is having a less cementation in my post-op X-ray. So come on, sir.
What did you do to the defects, which was one side was uncontained, medial side was uncontained, right?
Yes, sir. So both actually I have managed with only cement, sir.
That's looking. Any comment, Rajkumar?
No, it's actually well done. Probably Ashit brought it out the point. Probably on the uncontained side, he could have used a screw augmentation. So okay, would have made a little additional support because of the weight bearing axis. So that only the only point here. Otherwise, it is well done. The one key point here is in these kind of valgus knees, surgeons should make sure that they are not increasing the insert size too much. That means the bone cut has been done in a bigger way. So the bone cuts has to be as minimal as possible, and the insert size also should not go up, because the more the insert size, the chance of common peroneal palsy, and then the tightness, and then the balancing problem happens, then flexion deformity or extension correction. So many things happens just by making a mistake of doing more cuts, more bone. So in a valgus knee, the message should be that keep the mini cuts as minimal as possible, and you can go back and cut it whenever you want it. So that should be the message here.
This is after 2 months of surgery, sir. Due to the shortening in the hip, patient is having still limping, sir. Yes.
I don't think you are considering the shortening. It is not a shortening. So there hardly any major shortening. Because it is a valgus knee, it looks like that in a pre-operative. You thought that it is shortening, but it's not. There was no major shortening. So
also FFD was there.
Yes. So don't worry about it.
Okay, sir. Okay, sir. Okay.
It will improve. You have done a great job. Good job.
Good job.
Thank you, sir. Thank you for the opportunity, sir. Thank you once again, sir.
Thank you. Can you stop sharing?
Yes, sir.
So my next speaker is from Coimbatore, or Dr. Yuvarajan.
Good evening, sir.
Yeah.
So my screen is visible, sir?
Yes.
Good evening to all respected seniors, and thanks for giving me this opportunity to present my case on total arthroplasty and extra-articular deformity. And she is a 64-year-old female.
Just put in
go to
full screen.
Presentation mode.
Is it okay, sir?
Yeah, fine. Absolutely.
Yeah, she is a 64-year-old female with a known case of rheumatoid, and she presented to us with chronic bilateral severe varus deformity, with more significant on the right side. But patient had a stress fracture, but she could not recognize that stress fracture was there, but she was continued to ambulating with this kind of deformity. This is her clinical X-ray, bilateral APN lateral view with the skyline, and this is a scanogram picture. It shows that there is a proximal tibia stress fracture and it is malunited. It's been a chronic issue, and patient was not aware that the patient had a stress fracture with this kind of deformity. This was a preoperative X-ray. So the left knee is quite straightforward. I managed with
Wait, we will discuss first.
Yes.
Who will take the case? Dr. Patnaik?
No, he is not available. He's not well, it seems.
Okay.
Ravi can take.
The stress fracture is healed, no, doctor?
Yes, sir.
Yeah.
Very well.
Okay. I mean, as the mal, what was the this deformity, extra-articular deformity?
Angle side. Stress fracture, healed stress
fracture, sir. It is malunited.
Malunited. Did you calculate the deformity and how far it was from the joint line?
So it's almost around 15 centimeters from the.
Okay. So I would like, I mean, if there is a varus, gross varus with defect, and it's a tricompartmental severe arthritis on the right side. Okay. Anyway, we're dealing with the right side, no, doctor?
Yes.
Yeah. So there is no fixed flexion deformity.
No, sir. There is no fixed flexion deformity.
Okay. So then everything should be standard distal femoral cut and standard proximal tibial cut. As the extra-articular deformity is far away from the joint, and it appeared for me it is less than 20 degrees. Yeah, it's very less, like maybe around 15 degrees. So we can ignore it. Yeah, we can ignore it and do with the standard cuts and medial bone reconstruction with either bone graft or the screws with cement, whatever it takes. Should be fine with the.
Amir?
Yeah. Rajkumar, thank you. One of the main issue what I found is because there is an extra-articular deformity which is far away from joint, and we are correcting that extra-articular deformity in the intra-articularly, you might end up in doing a significant amount of medial release. That's one issue. and the one is she's rheumatoid and bone is very osteoporotic. And even if you to build up the definitely there will be going to be a big defect in the medial side. And once you definitely then you have to put a stem. Then the main concern that I'm thinking about my stem will go and hitch about the lateral cortex of the tibia. I was never able to bypass the stress fracture. So I had to prepare with a short stubby stem like 13 into 30 millimeter. Cemented stem would be my choice in that case. And definitely the medial side, either I'll put because I don't think the bone have a good union potential because of she's rheumatoid, the severe osteoporosis. I might use augments or screws with cement depending upon the depth of the medial defect.
Dr. Narayan, please.
Yeah, so this is an extra-articular deformity. So whether we can do it intra-articularly or do you have to do an extra-articular correction? That is the question here.
Yes.
Now that can be answered if you draw a line along the distal tibia, which passes proximally onto the tibial plateau. If that line goes lateral to the tibial plateau, you will not be able to correct that intra-articularly.
Exactly.
Whereas if it is inside the tibial plateau, you will be able to correct it. However, there are some studies, a lot of them, Korean studies, for example, if you use navigation, most of these deformities, even if it is going outside the tibial plateau, we can correct intra-articularly itself. And these deformities are easier to correct if they are in tibia and more difficult in distal femur because it's in tibia, it's okay. Now, another thing here is if that fracture is nicely healed, completely solid, we are okay. Otherwise, we may have to, because it is a stress fracture, it is not like a trauma deformity. If it is still weak, probably we may have to correct the deformity and pass the extension stem through the stress fracture so that, we have stabilized the fracture as well. And if we are going to do that, I think, that will be much easier than correcting the deformity intra-articularly.
Absolutely correct.
Post-operative X-rays or intra pictures do you have?
Yes. So, shall I proceed, sir, for the next slide?
Dhiraj, proceed. What did you do?
X-ray.
This is a standard, sir. I managed with standard implants with the extension stuff for left side. So this is the challenges which I planned for this case, right knee, the preoperative planning, assessment and pre-op planning for deformity, choice whether to go for a single stage or two-stage corrections, and anticipating there's some post-op complications. So this is my preoperative planning. It shows that the total varus of around 32 degrees. The joint line, which is contributing the varus intra-articular is 17, but this malunited proximal tibia is contributing almost 15 degrees of varus to my intra-articular deformity. So if it calculates, it is a quite significant deformity. So I thought better to address the deformity first, then to go for intra-articular release. Otherwise, as one of the panelists correctly mentioned, we have to go for very extensive medial release. So this is my planning. So under the C-arm, I took a lateral closed wedge osteotomy from exactly at the malunited part of the tibia. And the same level, I removed the wedge of fibula. So this made my job very easy and become the deformity is almost 15 degrees in the joint now. And it became a standard total knee arthroplasty. But during the preparation, and you can see I prepared the canal reaming both. When I opened it, I prepared this canal to pass my stem extension. So it made my job easy. It was a bit sclerotic because I've already united. So I reamed completely both proximal and distal. I prepared like passing a nail. So my job was very easy. Then once I prepared a standard TKR, so I passed a regular stem. This is my post-op X-ray. But before that, I stabilized the tibia with the DCP plate and distal 3 and proximal unicortical just to make the rotational stability. And I left the plate in situ. I didn't remove that because I don't want to get any stress fracture. But this stem I used was a 12 into 150 mm stem. But this was quite rotationally stable stem. And this is the immediate post-op pictures.
Yeah, I think quite a good job.
Yeah, just very good. And definitely, as it was discussed, this is a very good case for definitely correcting the malunited stress fracture, bringing it to neutral alignment, and then putting a stem. The only point here is I would have just to add upon, the stem size could have been little longer. Here, the stem is slightly shorter because I know in this Smith & Nephew stem, this is the maximum length. If you had used a Johnson & Johnson, you have a 160 stem, it would have crossed a little more. And when you get a good purchase, sometimes you may not need an additional one. But whenever you are doing an osteotomy, malunited stress fracture osteotomy, it is better to add just a unicortical plate. That is always better.
Absolutely.
Yes, totally agree.
Nice. So thank you. Great job.
So, one more point on this. So, sorry, a couple of things, because it has been done openly, because the osteotomy will have to open the fracture site. I would usually add the bone graft taken from the distal femur and proximal tibia.
Yeah,
That's one thing I'll do. Second thing I'll also do is make this stem little longer until the medullary canal is little wider. Because one of my patients had a stress fracture at the tip of this stem, the smallest fall. So I think that's another point. As the stem becomes longer and longer, it becomes a little rigid construct, and these patients come back with a periprosthetic, which is again going to be a difficult situation.
Okay, sir. Thank you, sir.
Thank you. Any stop sharing? Yeah, please. Next speaker is Dr. Kanav. He is from Jammu. Please share your screen.
Yeah, good evening, everybody. I hope it is the screen is visible now, sir.
Not yet, Kanav.
Not yet.
Okay. Yeah, thank you for giving the opportunity to present this case. So my case is a total knee replacement done in a post-tubercular arthritis. So a 55-year-old diabetic male present.
Kanav, your screen is not visible.
You'll have to share the screen.
That green button down in the lower panel, there is one green arrow mark facing up. Press that. In the bottom, there is one.
Yes. Yeah. Is it visible now, sir?
Yes.
Yeah, that's right.
Yeah, a 55-year-old diabetic male presented to the OPD with the pain and limping of the left knee since more than 2 years. So he had a history of ATT intake for tuberculosis of the same knee for more than 1.5 years. So he was diagnosed earlier on the basis of blood test and MRI. No biopsy, however, was taken. So currently he was having no constitutional symptoms. So this is an MRI of the left knee taken 2 years back, and at present, the clinical examination, he had a severe intelligent gait, very stiff knee, range of motion was 30 to 70 degrees, no varus and varus or AP instability, skin was normal, and there was a mild shortening also. So, sir, let me play the video of the clinical examination. So here is the only range of motion he was having, very stiff knee. But there was no varus or varus instability. So the current investigations were, sir, CBC was normal, ESR was 50, CRP was normal, knee aspiration I did preoperatively, there was a dry tap, and MRI, some edema and synovitis was still present, which was done again. Sir, I am audible, sir?
Yes, very much. Please go ahead.
So, sir, these were the pre-op X-rays we took just before the surgery. So, should I stop, sir?
Yeah. Yes, Ashit.
Yes. Okay. So this is again residual post-tuberculous arthritis, as we call it. I mean, obviously, from the clinical picture and the laboratory tests, it shows that there is no active disease. But you have to make sure that there is no active disease by doing procalcitonin levels also. That CRP is also fine. I mean, CRP you said is normal, but make sure that this are normal before you plan the surgery. As far as the surgery is concerned, it is a flexed flexion deformity, as we discussed in the first case. That is something that you have to follow those steps to release the distal femur and the posterior aspect of the femur, the soft tissues and the osteophytes, which we don't see here much. It may be just the soft tissues. However, there is on the tibial side, there is that little, there is a cavity which we can see on the X-ray, which you have to be prepared that if in tibial cut, there is a cavity that opens as a contained defect, you may have to be ready for putting it with bone graft and put a stem just to cover that bone. But apart from that, whenever you open, make sure that you do that thorough synovectomy and send that entire synovium sample for histopathology and microbiology.
Yes.
Ashish, they must start pre-operative. If it was proved AKT, they must start pre-operative AKT at least minimum for 3 weeks.
3 weeks.
Minimum. And all 4 drugs before we embark on the surgery of these patients. Because there is always some amount of minor microorganism which you will not be able to pick up. And the MRI actually, rather than we study, actually you must consult your MRI expert actually, because there is a lot of things which have come with the tubercular arthritis, especially in the hip also. So that is one important message, that AKT must be started before this surgical intervention.
Sir, even after he has completed 1.5 years of course.
100%. Even at 10 years, if even 10 years back this patient had a tubercular arthritis and it was proved, it has to be started. There is no question.
Now, there are 2 more points I wanted to add here. One is that this patient's ESR is still high, very high, and also his MRI shows there a continued inflammatory reaction.
Yeah.
Now, it could well be a multi-drug resistant TB, you see, which has been seen in so many places.
Absolutely.
So even though you have treated them so much, if you do a TKR without confirming that, the ongoing destruction will make that TKR fail very quickly. So I think we'll have to plan for that, as Dr. Pachura was saying in the previous ATT, and reculturing them for the MDT. And if necessary, we may have to continue that for a long time. That's one point. If there is a persistent infection, and if we think the ongoing TB infection is there, another option which I had done in a hip patient was doing an excision arthroplasty with a spacer and then going back and doing a replacement.
Yeah, Dr. Narayan, just for discussion
Except in
point of
TB,
view,
yeah, that's what I think you're going to tell me. Yeah.
No, discussion point of view, you said the chance of multi-drug resistance is high in this situation.
Not in this situation, in this country generally.
But even if you assume that already 2 years he has taken, and now if you are again thinking of multi-drug resistant and giving him AKT4 again, so that means that AKT4 should not work in this situation.
No. See, if it is an MDT, you will not give him AKT4.
That is the point.
You will consult your microbiologist local, and he will usually change them to a second line drugs.
So in this, when you operate, you take the synovium, take the tissue synovium and for everything. Today we have a lot of newer biology, molecular pathology. So great thing is happening in this country. So you will be able to know what is it drug resistance also, rifamycin and Isonex. Gene expert and few other things, ultra gene expert. So
we have to wait till the culture report and histopathological examination report comes.
Yeah.
And based on that, yes, Mrinal.
What is the role of preoperative aspiration in sending it for gene expert in such tuberculosis?
No, he has already done. He said it's a dry trial. That's why otherwise that is the most ideal way. That is the most ideal way, that because he could not get any fluid from there.
Would you, in that case, consider an arthroscopic synovectomy?
Yeah, you can do you can take a biopsy also.
Biopsy is better option than aspiration.
Yes.
Last week, one case I stuck in Jaipur and just did the arthroscopic biopsy and sent for the TB gene expert.
So all this biology, molecular biology we are talking about can be done by arthroscopic synovectomy. You will get good sample. You have those 2, 3 weeks, 4 weeks to get the results back, start the patient on medical treatment.
Yeah.
Yes. As such, joint replacement is not a contraindication in non-active tuberculosis. So as we are doing during the procedure, we can send for all cultures, gene expert, line probe assay, and wait for the cultures and start the specific drugs. That should be better.
Chaurasia, sir, what antibiotic would you like to add in the cement in such cases?
The people have tried streptomycin, but I am not very keen on that. but I don't know whether it is a thermostable or really don't know. So people have, especially in the hips, cemented hips, in our country, to name Dr. Bosle has done a good work on this, and he used the streptomycin in the cement.
So, sir, what about using stimulant with streptomycin in such situations?
I think stimulant is not a good option, but streptomycin you can have actually wash also with streptomycin. Stimulant, sometimes what happens, they start oozing and then you secondary infection develop, then you are in trouble. Trouble.
And second thing, in the tuberculosis, it doesn't have glycocalyx like other bacterial infection. So
No,
the formation of the biofilm is very biofilm doesn't happen in Mycobacterium tuberculosis.
I agree.
So
That
we
is
need
the
not to
reason
worry about adding antibiotics and all. So we should worry as we are taking the entire diseased part of the bones and also the synovium. So there will be less chance of any persistence of the infection. If it is there also, we can treat with AKT. It's the only thing, if it is active, we should not do.
I am talking about now 25 years, 30 years back. I did a couple of knees. My boss did a couple of knees. And post-operative, when we saw the synovium was born, we sent it for, we did a TKR at that time. And we sent the synovium, it came out tubercle. And luckily, immediately we started anticox and nothing went wrong. So you are lucky that tubercle organism has three important factors. One, they are slow growing organism. Second, they are paucibacteria. Third is, you said there is no biofilm. That is another one important finding. And today we have a fantastic drugs available, and that is the reason we are able to come out of this complication. So we have done this path. Nothing to worry about going ahead, but be scientific. What I want you to put it. Be scientific.
So, sir, if we go from your experience of doing those joints where you incidentally found it was a tuberculosis and you gave him AKT. So now what is the point in giving an AKT pre-op when this patient already had 1.5 years of AKT?
Yes, I will tell you. The reason is there is some pockets of remaining which will never come out because it is a very slow growing organism and it is a dormant disease. So you will never pick up Ashish with this, and that's why it is better to protect them by AKT of 2 to 3 weeks. In hip also we do it, knee also we do it.
And then post-op continue for how long?
Post-op, suppose that patient comes negative, all the factors are negative. You continue for another 2 to 3 months and stop it. And suppose if the one becomes a positive culture, then you continue for 14 months or 16 months, depends on your medical man. So usually, by and large, in our India, most of the surgeons have used up to 12 to 16 months. That is 12 to 16 months of AKT. But if it is negative, stop it at about 2 to 3 months time.
Okay.
That
Go
is
ahead.
accepted.
So this was the current MRI. Sir, the preoperative apprehension was a stiff knee, tibial bone defect, intraoperative infection pus, and chances of postoperative infection. Patient was counseled about the issues and stage procedure if necessary. So the intraoperative medial parapatellar arthrotomy was done. Patella was very adherent to both the femoral condyles. Had to use an osteotome to make a groove and then work gently. So more than usual thickened intrapatellar fat was found. As contrary to some rheumatoid arthritic knee, the synovium was very hard in consistency and it was extending well above the suprapatellar pouch. Quadriceps were very firmly tied to the femur and had to do a periosteal stripping up to 7 to 10 centimeters or even more during and even after the completion of just before the closure. So the medial and lateral gutters were cleared carefully as to not to damage the collaterals. No infective granulation tissue or pus was found. It was very difficult to subluxate the tibia anteriorly. Lateral tibial condyle was more posterior as compared to the medial. Both the tibial condyles were symmetrically worn out more so, and the central eminence was prominent. So standard 8 mm and the femur cut was taken more 11 mm with a 5-degree valgus. Sir, medial soft tissue was here. It is a picture. It may not be very good. So the patella is very adherent to the femur, and even after the completion of the procedure, I was not able to fully correct the FFD. So after cementing, here is the picture that I am even not able to. Some 10 degrees of FFD is still remaining, even after taking more distal cuts as well as aggressively stripping the periosteum of the distal femur as well, sir. So I was relying more on the post-operatively. Intraoperatively, cultures were sent and specimen for histopathology. No growth of organisms after 72 hours, and in Hon histopathology, it was a non-specific synovitis, and it was there was no evidence of any granuloma or neoplasia seen. Sir, intra-articular drain was kept, wound infiltration in the cocktail, and a watertight closure was done. Sir, I may add that due to the stripping, I only added an intra-articular drain, and it was like in 24 hours, it was more than 300 to 400 ml or even more. So post-operatively, I use a ciforaxime 6 doses, 7 days of linezolid, and I have put the patient on 3 weeks of ofloxacin, epidural top-up, CPM, echo.
Can you show the X-ray?
Started the next day. Aggressive physiotherapy done. Yes, sir. Just a minute, sir. Sir, here is the on the stitch removal on the 15th day. The FFD has reduced, and he has got flexion also. So I think post-op X-ray is still, I think. Oh, sir, just a minute. I'll show you the post-op X-ray.
So, Pajari sir, while he shows the post-op X-ray, any immunocompromised, like especially tubercular patient, it is better to send fungal culture also in drop.
Yes, sir. Sir, can you see the post-op X-ray, sir?
Yes,
Yeah, we can.
Yeah, sir, here is the post-op X-ray. I have not resurfaced the patella and did a usual TKR. So, sir, here is that.
Thank you. Any comments from the panel? Dr. Rajkumar?
Yeah, yes, it is actually well done for the complexity and the doubts he had of whether to start ATT, how to proceed. The flexion deformity was the one which is really a challenge in this case to do it because of the lot of additions, unlike in the regular flexion deformities. So he has done a good job, and the maximum release he has done, and probably because of the residual flexion deformity, he might be having a small deformity, flexion deformity post-operatively, but I think it's a well done job.
Great, thank you.
Great.
Sir, I have not yet started a post-operative ATT, but anyhow, I'll start now. Sir, after this, hearing the discussion.
I think now with the cultures and everything negative, I don't think he needs any post-operative AKT or anything. Now it's proven that he doesn't.
I think Rajkumar, he must protect it. If he's recently operated, you must start AKT for at least for 3 months. 3 months. If histology diagnosis of previous, which was there already.
And also, there is no mention about the TB culture. You see, he has got no culture at 72 hours, but not after 4 weeks.
So we need to go a little longer time, and we have to extend the culture because it is not going to be in a couple of days. You have to wait for TB culture for at least for a period of 6 weeks. So I think it is better to protect. We are not doing any harm for this patient.
Yeah. He's operated.
If his liver functions are all right, he should start.
Yeah, okay, sir.
So next.
Yeah, okay, thank you, sir.
Thank you.
Thank you, Kanav.
Thank you.
So next is speaker from Bangalore, Dr. Basavaraj, CM.
Hi, good evening, everybody. Once again, my talk. Is that clear?
Yeah.
Absolutely.
Yeah. My talk is going to be on a windswept deformity. I am Dr. Basavaraj. I'm heading the orthopedic department at BGS Gleneagles Global Hospital, Bengaluru. So, it's a 55-year-old lady who presented to us with severe windswept deformity. That's valgus on the right and varus on the left. She had also very bad pain. She was really, it was disabling. Almost 1 year, she couldn't walk long distances. She was home bound. And you can see she also had a severe flexion deformity of both her knees. This was her X-rays. That's the lateral view. And on table, just wanted to show you how much of instability was there. So demonstrating the defect on the medial tibial plateau. This is on the left knee. This was the knee with the varus deformity. And this is the right knee. On the right knee, it was the defect on the lateral tibial plateau. And it was almost looking like a horse, saddle, the proximal tibia. And this is a video showing the instability of the right knee.
What was the status of the MCL and LCL? Collaterals.
So what do we do?
Yeah. So case is open for the panel. Who will take the case? Mrinal.
Yes. Did you get an MRI
Yes,
preoperatively? Did you get an MRI preoperatively to assess the collaterals apart from the clinical assessment? Can you hear me?
Am I audible?
Yeah.
Yes, yes.
So I am asking, did you? Dr. Basuraj, we can hear you. I was just asking, did you get an MRI preoperatively apart from your clinical assessments for the collaterals? Because
I can't hear.
Okay, Mrinal, I think there is some audio problem with him. You go ahead, Dad.
No. Sorry, I can hear now.
Okay.
Yes. So I was asking, apart from the clinical assessment, did you get an MRI for collaterals? Because the collaterals are too much stressed, and also there are a lot of bone defects.
No.
And subluxation.
No MRI, just clinical assessment.
Okay. So obviously it's a Windsor deformity. We need to go ahead and build up the defects, do minimal release, and obviously keep constrained implants, including hinges, ready in such severe situations, especially on the left side where the tibia and the femur are almost subluxed completely on the lateral view. Anything else someone wants to add? A routine knee, I don't think is going to be a solution in such situations.
I know it is painful, but just get an MRI of the spine, just to.
We got the X-rays. We evaluated the spine. It was normal. Spine and the hips.
No, only one point about.
I know. We want to see if there's a Charcot's or some sort of.
I know it is painful, so it cannot.
That was evaluated. That's normal.
Okay.
With this type of dislocation, I agree with Ashit that you must get an MRI done, because this type of dislocation does not happen with osteoarthritic knees. So be careful with this type of knees. It's an anterior subluxation tibia.
Yes.
Be careful with these patients.
Maybe we should get a synovial biopsy as recommended by Dr. Anand during surgery to rule out Charcot's.
I am not going against your clinical examination. When I saw her walking on the right side, on the valgus side, I think she had a foot drop on that side. Anyhow, please go ahead.
We did a standard TCAR, unconstrained. So bone grafted the defect, and clinically also the collaterals were intact pre-op. As well as on table, I could see that the collateral mechanism was intact. So unconstrained, posterior stabilized. Just to offload the reconstruction, we have used these stems. So that's lateral. We used navigation, so got a decent correction of the mechanical axis. And that's 6 weeks post-op.
It's not a decent correction. It is a very good correction.
Excellent. Excellent.
Thank you. And that's 1 year. And that's 1 year post-op.
But the right foot drop still exists, it looks like.
That's okay. That's okay. I think,
So it was there pre-op also because Dr. Pachare picked it up pre-op. So
I'll tell you one thing. I'll be honest. She had a fall just 2 to 3 days prior to the surgery, and she developed this foot drop. It was a peripheral nerve lesion, and I didn't want to add on all those things, because it will dilute. The take-home message in this is the importance of collateral mechanism. So I'm not stressing on anything else
That's
here.
okay.
So she had a foot drop, a right-sided foot drop, and we waited. We thought it was neuropraxia; it will recover, but then it didn't. It's 3 years now, 3.5 years. So it has not recovered. We have done the nerve conduction studies and all that. So probably we may have to, but she's managing with a foot drop splint and she's fine. But we have discussed the option of tendon transfers.
Now, is that gives us a clue that it could be neuropathy?
Because no. Can you stop sharing simultaneously?
Because of fall, just 2 days and prior to the surgery, she had a fall and she had this foot drop.
Dr. Basuraj, can you stop sharing while discussing? Can you stop sharing?
Dr. Basuraj, see if it is a closed injury, if it is a closed injury and patient has developed neuropraxia, probably that should resolve. It is now 3 years. So definitely we are looking at something else. This is not neuropraxia.
Yeah. Stop. Yes.
Yes.
Dhiraj, you can invite the next speaker in the meeting.
Dr. Basuraj, you've done a very good job, but I would still like to use constrained implants in such situations because of all risk of late MCL laxity and ruptures, in these, especially in the valgus knees. So I think that consideration should be kept in mind, always doing such severe deformity.
So I had kept that on the shelf, but the collateral ligaments were intact. I have a 3.5 year follow-up. I have been following her up regularly. I have the X-rays at 3 years now. So she's absolutely fine. And Dr. Pachare, you really picked up that point of the foot drop. She has that foot drop. We have discussed
that's
about
okay. That's okay.
Yeah.
And I think that's okay. You have done a good job. And less constraint is better because you don't require to use too much of constraint. If
yes.
If you have good ligament, I think you should be okay. And if 3 years she has not ruptured, she won't rupture.
She's not going to rupture.
No, she's not going to.
And also opening was partially due to defects, bone defect.
Yes,
That's
everything is yes. Take home message. I didn't want to present the foot drop and everything, and for the Charcot's neuropathic thing, we had evaluated her spine, and there was and she had severe pain and all those things. It was not like that. She didn't have pain and all that. So she was in fact on Voveran diclofenac for almost, like his son was telling, almost every week. She was on injectable Voveran and also oral aceclofenac.
You should intraoperatively send a synovial biopsy, and if it shows bone pieces, that is somehow diagnostic of Charcot's. That is what Dr. Anavat has taught us.
Disorganized joint with bone pieces.
Yes.
Next speaker is from Olachi Bottom. There is screen.
No, Dr. Basuraj is stopped.
Sorry.
Is my screen visible, sir?
Not yet. Not yet. Rajkumar, just guide him, I think.
Anil?
Yes, sir.
Are you able to locate the share screen button?
Yes, sir. I'm just clicking on it.
So in yes.
Yeah, it should be.
Is the screen visible, sir?
Yeah, go to full presentation mode.
Yes.
Yeah.
Good evening. Myself, Dr. Anil Gautam from Anand Hospital, Pollachi. Today we'll be seeing cases about orthofix assisted extra-articular deformity correction in TKR in various OANEs. So this is a case of 75-year-old male who had bilateral osteoarthritis of the knee joint with various deformity, had difficulty in performing activities of daily living, an economically poor patient. Clinically, his range of movement were between 5 to 90 degree. This is his clinical picture, and both knees, AP and lateral views on weight bearing. So we will consider only about his left knee because he came for pain in the left knee. This is his full length scanogram of lower limb. So the treatment options are. Can I go ahead with the presentation, sir?
Yeah, please go ahead. Yes.
Yeah. So we have planned for left total knee replacement, and we have planned for correcting the extra-articular deformity with orthofix external fixator, what we routinely use for high tibial osteotomies. So preoperatively, we have looked for the entire length scanogram, and also we located the cora was at the proximal tibia. So we thought of correcting the deformity extra-articularly so that we could bring back the biomechanical axis to the normal range. So we do a lot of HTOs with orthofix applicator. So with we thought of correcting the deformity extra-articularly with the orthofix assistance. So we opened up the left knee with medial parapatellar approach. This is the picture after exposing the knee joint. See, we connected the orthofix external fixator in the two horizontal pins in the proximal tibia. The horizontal pins are just inserted in such a way that anterior and posteriorly that won't interfere when we are doing the tibial intramedullary preparation, so that it won't interfere the tibial stem preparation. So and two vertical pins connected to the distal shaft of tibia. Once the proximal and distal pins are connected, this makes the tibial site a stable fragment. So once the orthofix, this is the picture after connecting the orthofix external fixator. Once we connect the orthofix external fixator, we use the cautery cable to locate the cora which we have assessed preoperatively, and we do a open wedged osteotomy at the site of cora. The size of the osteotomy could be adjusted with the orthofix. Still, we get the biomechanical axis corrected with the cautery wire on table. So this is how we do, either with the cautery cable or with the rod. So once we achieved this, for this case, the preoperative cora was around 12 degrees. So once we achieve the osteotomy, we just stop it. So even after the osteotomy, there is extra orthofix in the tibia, it makes the stable fragment. We can go ahead with proceed with the TKR. So once the osteotomy is done, then we go for routine distal tibia and distal femur cuts. And these are the pictures taken while we are doing the tibial preparation. So once this is the picture after the trial processes of tibial tray with the stem. So once we do all the tibial and femoral cuts, we stabilize the osteotomy site with the unicortical recon locking plate and screws. This is after inserting the trial processes after completing the bone cuts. So we take the cancellous bone from the bone cuts, or the tibial and bone cuts, and we pack at the graft at the osteotomy site. So after packing the graft at the osteotomy site, we proceed with cementing of the implant. This is cementing of the final implant. So this is after completing cementing. Once the procedure is done, the cementing is done, then we remove the orthofix external fixator, and we give a wash, and we just close the wound in layers. This is the postoperative X-ray after correcting the deformity. The immediate postoperative X-ray, and this is the postoperative X-ray of the left lower limb after 2 months. So postoperatively, we follow up the patient with wound management, and he was put on toe touch weight bearing for the first 3 weeks, and gradual and range of motion as tolerated. This is his post-op follow-up X-ray and range of motion. This is the pre-op and post-op clinical photograph. This is the pre-op video of the same patient. This is the post-op video. You can see appreciate the alignment of the limb.
So we are running out of time. So Dr. Rajkumar, final comment on this case.
I want to.
Yeah, please, Narayan.
Narayan, please. Yeah.
No, it's a very nice, beautiful demonstration of the technique in difficult, complex cases. But for the particular case, I don't, feel that all these things are needed. One thing, and usually my principle has been, don't make the simple operation very complicated like this. Honestly.
Okay. Just to add one more small point, a patient with severe varus, these kind of varus deformities, when you bring it to little more valgus, it becomes very difficult for the patient to get a satisfactory mobility. So in fact, patient will not be so much happy. Maybe in this case, okay, but routinely I'm telling. In fact, now the concept is going for little bit of under correction rather than valgus correction. So valgusation is not an ideal one in these kind of situations. So otherwise, the technique wise, yes, it's a good technique to have it as a armamentarium, and that's a very good.
We just use orthotics as a tool to correct the deformity extraarticularly.
Yes. Very good, very good.
Yeah. Thank you.
It's innovative.
Excellent job. You can stop.
Thank you.
So today's last speaker, Dr. Narayan, who is from Bangalore.
Okay. Can you see my slide?
Yes, yes.
It's going to be quick and I'll not bore you long. So this is a 57-year-old lady who had a knee arthroscopy and a meniscal balancing. It is the surgeon's own word about 2 years ago. More or less, we all have stopped using arthroscopy for osteoarthritis, but this was done. Only important point to note is this patient never had a valgus deformity before the arthroscopy was done. It was a medial meniscal tear in the MRI and an osteoarthritis. That's how she was walking with, before I saw. That is about 2 years after the knee arthroscopy. Now, these are the x-rays of this lady. You can see a standard valgus. There is a standing stress view of the right knee. You can see quite open on the medial side. And this is the MRI scan of the knee, standing long x-ray. MRI has been reported as severe osteoarthritis with the fluid intensities along the MCL and also a small cyst on the posteromedial aspect of the medial collateral ligament distally. And it's open for discussion.
Yeah, Dr. Samir?
Yeah, one of the most, as per the history, it can be because of the tight medial compartment to do a posterior meniscus work. He might have tried some pike crusting of the medial collateral ligament as a routine of many of the arthroscopies.
Perfect.
So that might give a MCL giveaway, and eventually the patient developed a progressive valgus deformity. And that might be the reason why it is happening.
Yeah, it could be. And I would, because it's a valgus knee, as a protocol, you have done the spine line views in the long knees, you can see. And this is on table, examination on table, you can see that. See, it's going about 45 degrees of valgus. And I have put an unconstrained trial on table just for examination. You can see how much the medial side is opening compared to the lateral side. So I thought I will do some innovative thing. I dissected out the medial meniscus. I thought we'll see the meniscus. It was completely off distally. There was a cyst distally at the site of the pike crusting. Hematoma was there as well. Now I have taken that distal part of the meniscus like an ACL whip stitch, and I also harvested a semitendinosus, keeping the distal insertion intact, and then used an interference screw, metal screws, both sides, normal screws, and reconstructed that MCL using its original MCL plus the semi-T, which I have taken in a standard manner, whatever the way I could do, and tightened in around 30 degrees of flexion with a normal trial first. And that is the picture of that ligament which was reconstructed. And that is the post-op X-ray. You can see the two interference screws reasonably, the deformity has been corrected. This is not a normal standing X-ray because this was done last week. So it looks like a little, not a normal standard X-ray is what we see. And by the time I finished that case, I saw another one. This is an evidence of the root repair of the posteromedial part of the medial meniscus, which obviously was a degenerative tear in this patient. Seen an arthroscopist who had done a root repair. While doing a root repair, again, a pike crusting was done on the medial side, and you can see what has happened. So probably this talk should have been on an arthroscopy forum, but however, I thought we'll all educate ourselves. Thank you.
Narayan, why did you put the stems? This was an unconstrained knee.
No, it is unconstrained. You see, always, whenever you do an MCL repair, however good you may be, you are not sure how good you can be, and you put some support with a constraint. Yeah,
this is a constraint knee.
Yeah, it's a constraint. You can see that
constraint knee.
Yeah.
Was any stress views taken preoperatively?
It was there.
Here you go.
Yeah,
it was there. Narayan, only one thing, if you have some part of the medial ligament, this repair will work beautifully. If you do not have anything, no substance on the medial side, and if you just do a semitendinous, the failure rate is very high.
Yeah.
Protect this patient with a brace for a longer time.
Actually, in fact, I have put a plaster on there. You don't believe it. Because
no, that's okay. No, even after plaster is removed, after even 6 weeks or so, so protect the knee in some ortholon type of brace, so that you have something on the medial side which will hold on till you get a good fibrosis.
Yeah.
So
even with the constraint design, we have to do that. Semi-constraint design.
Even with constraint, because this is not a hinge; it is just a constraint. You cannot
rely on it.
Rely.
So what's your Rajkumar? What's your experience in MCL reconstruction in TCAR?
MCL reconstruction.
Yeah.
See, it's a totally different story in this. The MCL reconstruction is reconstruction for what is the most important thing, whether it is an acute injury or a chronic problem. If it is an acute injury, totally it is different. So all this repairs can be done end-to-end suturing and then augmented with all this grafts. But if it is a chronic condition, then the chances of, as Pachore sir said, the chances of reconstruction will not work. The options are very, very less. So you have to have a hinged as a backup. So there is no stem or any, just a small semi-constraint will work for an MCL insufficiency. As simple as that. If it is acute, all this augmentation will work. If it is not acute, I don't think any augmentation will work. If it is an avulsion injury, MCL avulsion injury, then the results are good. You just need to fix it with screws and just protect it with the brace, and it will all work out well and it will heal well.
And you can see in this picture, the MCL which I have dissected out is quite good because it was just the distal avulsion exactly where they have done the pike crusting.
Pike crusting usually in the substance, like in artificial joint reconstruction, the joint reaction process, what they create, we usually depend upon only two collaterals. Very difficult to, I don't know how many years follow-up we have, sir, now?
No, this just done recently.
No, this is just an arthroscopy who has done a pie crusting, which has given away the medial collateral ligament. Yeah.
And yeah, this is a good to. We never seen this. Thank you.
I have seen two now. You see.
We've never seen that.
Once it comes, it starts coming.
Yeah,
I think it's very rare to see this.
Honestly, this the posterior medial meniscal root repair has become quite popular. Maybe that may be the reason.
But the success rate is not that good. Like the root repair, they come back with failure very quickly. The meniscectomy works well, but not the root repair.
You can be telling that nicely in this forum.
No, I tell even to my arthroscopy surgeons, I keep telling them the same.
So
yes,
what's
Dr.
the take-home message?
Thank you.
Narayan and Rajkumar, take-home message. If there is a MCL tear and it's a straightforward knee replacement, if it is acute, then you can go ahead and take some grafts and repair it, Narayan. Otherwise, if it is a chronic one, then you need to use, either way you use a constrained, semi-constrained should be okay. But if it is a very chronic MCL, then it doesn't, it will not heal.
Yes, correct. And particularly in a valgus, gross valgus, when there is a MCL insufficiency, valgus, if you are not able to balance it, at the end of the day, it is better to use a hinged straight away, where a patient will do well, rather than having an unbalanced knee and without any constraint processes. So that should be, we should not use, hesitate to use a hinge in these kind of situations. A valgus with a gross MCL insufficiency.
Chronic.
Only, the real issue.
Acute one, sorry, Narayan, if it is an acute one, what does the literature say?
Narayan, can you?
I think going in for an unconstrained, what Narayan has done is really good because
it is a constraint. It is a constraint.
Semi-constraint.
No, it's a semi-constraint. Narayan, what you have done is semi-constraint, right?
Yeah. I'll just.
So the particles are lesser and the survival is better, isn't it?
No, Basraj, I understand your question. See, this is the situation. What is real is if you inadvertently damage the MCL during a trachea, that is an acute injury. How you come out? So the situation is whether you have a semi-constrained device on table or not. A lot of people, they don't have when they're doing these primaries. So in those situations, you may have to repair it primarily like a whip stitch and other things.
Sorry to interrupt. It is a mid-substance tear.
Yes, mid-substance tear. That's where the saw, So you repair and augment if you can.
The insufficiency is like the whole MCL is insufficient. It has become too lax and it is very much irreparable. So you cannot do anything. So that is a different scenario.
Correct. So that situation you can make out, in your pre-operative planning.
That is where the stress X-rays play a very important role.
Is important, and you have that chronic insufficiency of MCL with a valgus. You must have the hinge, otherwise you should not start that case. Yep. While what we are talking about is an acute injury intra-op, what Rajkumar has said is something that holds true.
Yep.
Over to Dr. Rajkumar. So
yes, I think we have come to the end of this second webinar, and it was very well conducted by Dr. Dhiraj, and the panelists and everybody were point on, and there was a very good discussion, I think, and there were a lot of take-home messages. I think everybody knows about all these managements, but there were small, nice points which were raised. And I think valuable points from Dr. Pachore and Dr. Indrajit Sardar really helped us to gain some knowledge out of this meeting. I think overall it was a very good one. And finishing remarks from Dr. Pachore and Dr. Indrajit Sardar.
Thank you, Rajkumar, for asking me to, but I think it was a good faculty, and every case was discussed extremely well with a very, very friendly manner, and nobody should take it in the in other way, because I pointed out the foot drop, so sorry about it, but that's okay.
No.
That's okay. But I think it was an excellent whole program was 2 hours. We really learned quite a bit of things, and especially I never saw the arthroscopic doing in a pie crusting and getting into the valgus. I think I also learned quite a lot of things from this one, and we should continue this academic activity, Rajkumar. And
sure, sir.
Yes, And and thank you all the presenters also, and thank you Dhiraj for moderating. And over to Indrajit, if he is there.
He's there. He's there.
Yeah, thank you so much. I think it was a very great experience. Enjoyed every bit of it, and thank you, Dhiraj, and especially Rajkumar for stitching everything together.
Thank you, sir, and thanks for the faculty for coming and spending time here, and also the presenters. They did a good job. Thank you, Ashok.
Thank you.
For all the support, and thank you, Dr. Navin and Dr. President also. Good night to everyone.
Thank you, everyone.
Bye-bye. Thank you very much.
Bye.
Bye.
Bye.